right. I'm going to go ahead and jump in. I'm so excited once again to be with you all to talk early Head Start stuff. We've had some really interesting conversations around early Head Start over the past 4 sessions, and this is our 5th. And the interesting nature of the topic is only getting better in terms of relevance to us and specifically designed for our early Head Start folks. So I'm very, very happy to be here today with Dr. Neel Shah, who's an assistant professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School and the director of the Delivery Decisions Initiative at Harvard's Ariadne Labs. As an OBGYN at Beth Israel Medical Center in Boston, Dr. Shah cares for patients at critical life moments that range from childbirth to primary care to surgery. As a scientist and a social entrepreneur, he's globally recognized as expert in designing solutions that improve healthcare. One of the things that struck me the most when I talked to Dr. Shah, honestly, beyond all of this incredible resume that comes with him, is the authenticity of his concern for people. And I think that was such a wonderful thing in the mix of all of this very intensive science and research and work, is this person who has a sincere desire to do good things for people. And I think that is a wonderful trait for anybody, but particularly at the early Head Start, in their early Head Start community, because I do think that our early Head Start folks are at the center of so much of this and do so in a very quiet way. So a lot of times they're in the mix, and it's not necessarily something that the general public is aware of. So Dr. Shah, I'm going to turn it over to you and let you take it away. And you've got this group just gets bigger and bigger every time we meet, but these are our folks who work with pregnant moms through age 3 specifically under the Head Start Act. Early Head Start began around 1995, so it hasn't been around as long as Head Start, but it is becoming more and more important with time. And so your research in terms of and your work with and concern for pregnant women, I think is really appreciated here. So welcome.
Thank you so much. I'm so thrilled to be here with you guys today. And I'm seeing in the chat that all of you are working across the country and trying to take care of people who are in this phase of life of starting and growing their families. And it's just really an honor to get to talk with you a little bit. And, I'm an obstetrician and a clinician and a public health professor. So a lot of what I've done in trying to think about maternal health, it comes from that perspective. It comes from trying to think about people's, kind of clinical condition and what happens inside the hospital. So I thought, what I could do is just really tell you how I have seen things, and really honestly how the last year and a half has changed my worldview a little bit. Let me start with, nope. I'll make this work. I can do it. You would think after a year and a half of Zooming. Boom, there we go. Okay. So I think the way that this talk was framed was around maternal mortality. And there's a good reason for that in the United States of America, and we'll get into that a little bit. But part of what I was alluding to in this kind of frame shift that I feel like I experienced, and I'll be really curious to hear how you guys are seeing this too, is in thinking about this issue of trustworthiness as being the existential issue that our healthcare system and our public healthcare systems have right now. In Boston, last spring, 2020, things were tough. We had people who were pregnant and needed care, and in some cases were feeling really sick and were having trouble breathing. But if they didn't meet criteria to come into the hospital, because there was like strict criteria, we would tell them that they just needed to self-isolate at home, and they would feel like dismissed or condemned, even worse. right? And for the most part, like the majority of the people who were calling in, like lived in a part of the greater Boston area called Chelsea, which was the hardest hit part of Massachusetts, and was mostly, you know, Hispanic families living in multi-generational housing, people who just really didn't have the opportunity to isolate or protect themselves in the first place. And then of course, like, you know, a lot of people would come into the hospital, and we would have visitor restrictions in place, and they couldn't bring their people with them, like even when they came in labor, and they already kind of felt over policed in their own communities, and they would see like actual police like blocking their way to come in. And then the people on the front lines of delivering care, you know, they were already burned out before the pandemic. And then during the pandemic, they had to get redeployed. They didn't have adequate PPE in many cases. They felt sacrificed. And in some cases, they felt blamed for a lot of the inequity that we saw. That's really what COVID-19 did, right? It took like every inequity in our society and threw it into a pressure cooker. And I've really felt for a long time that maternal health is sort of a bellwether for the well-being of all of us. If moms are unwell, society is unwell. And that's why we see every injustice in our society show up in the well-being of moms, whether it's racism or issues of gender inequity and misogyny, or even geographic inequity. When we look at what's happening in rural America, even this idea of generational inequity comes up in maternal health. It turns out an American today is 50% more likely to die in childbirth than her own mother was. An American today is 50% more likely to die in childbirth. And you know, this whole theme that both presidential campaigns had last fall, one was like, you know, make America great again. The other was like, build America back better. But either way, it was about this idea that hope and opportunity in our country is eroding. And we see that in the outcomes of people who are in the phase of life that you help take care of. So that really made me think about this issue of trustworthiness as more than a virtue. Of course it is a virtue, but I started to think about it as an output of a system that's either working or not working. And so that's really what I want to think with you about today a little bit, particularly in the context of the work that you do. So I lead a research and social impact program at Harvard University. I practice obstetrics, but I also lead this research program that has a vision statement for a world in which every person can choose to grow their family with dignity. It turns out that not only are Americans 50% more likely to die in childbirth than their own mothers, but if they're Black, they're 3 to 4 times more likely to die. And for every death, there are 100 cases of severe injury. There are tens of thousands of cases of suffering from undertreated illness. And then, as you all know so well, there are probably hundreds of thousands of people that are suffering from the general economic disempowerment that seems to come with motherhood in America. And that's why we sort of phrase or frame up our program that way. And as I imagine you know very well too, people's opportunity to thrive is so tethered to where they are and where they live that even within a very small geographic radius in a city like New York, where my family is from, there's a huge difference between like living in like Jackson Heights, Queens, or like, you know, like Soho in Manhattan. It turns out, you know, you're 3 to 4 times more likely to die in childbirth if you're Black in America, but you're 12 times more likely to die if you're Black in New York City. And again, that's because of the way that people's opportunities to be healthy, to attain educations, all of that are really separated by where they live. And this is true like in every city in America, you know. So honestly, over the past generation, our whole healthcare system and public health infrastructure, but particularly this really critical period of our lives where people are pregnant or giving birth, it's become less trustworthy. And there are all these statistics that back that up. And in fact, if you were to pick 3 statistics, turns out from the last generation to the current one, the amount that we intervene in childbirth, and this is what's so kind of like mind-blowing, it's not necessarily that we're not providing enough care. In some cases, that is definitely true. In other cases, we're providing too much care. You can hurt people by doing too little, too late, and by doing too much, too soon. But our C-section rate in our country has gone up by 500%. That's a major surgery, and it's designed to save lives. And yet term infants are 0% better off as a result of that 500% increase on average. And moms are 50% more likely to die. So that's the state of affairs in the United States. And then, you know, it turns out that trying to understand why it's not straightforward. One way that you might do it is look at what's on the death certificate when people die. And if you went to like the CDC website, that's what they would do when they track vital statistics. And it would say like hemorrhage. And you might think there's a lot of Americans dying of hemorrhage. But it turns out there's a lot of people who survive severe hemorrhages and a lot of people who don't survive more moderate ones. The difference, 80 to 90% of the time, are failures of communication and teamwork. And that probably doesn't surprise you at all, but it is kind of remarkable the degree to which we're not intentional about that root cause as something that's clearly deadly in America. So just in thinking about this issue of trust, it's occurred to me that, part of what we need to do is make sure that our system is competent. And that means like our healthcare system as well as our social safety nets, but like we have to be able to produce positive, equitable outcomes. It also turns out like it's not adequate to be trustworthy. Like the way that you produce those outcomes matters too. You have to be able to show up for people when they need you, which is not something that we do very well, particularly during the pandemic. We suspended a lot of services. We decided prenatal care was not among the services that was essential. So a lot of people didn't have access to prenatal care during the peak of the pandemic. Fertility services went away entirely. And then, the other thing that I think is really key here is that you have to be able to ensure people are seen and heard, for lack of a better term. And again, that seems really obvious, but the entire enterprise to make our healthcare system safer over the last 2 or 3 decades has had this really narrow idea of safety. Almost to the extent that we sort of consider people's experience a secondary luxury that we tack on after we've made you safe. Like honestly, very few people would choose to give birth in a Johnny on a hospital bed under fluorescent lighting, tethered to a bunch of wires, unless they were like, this must be the safest way to do it. But what we're increasingly learning is that it might not be, first of all. And second of all, in almost every story of maternal mortality, particularly among Black Americans, what happens is that people express concern about things that they would uniquely know from their lived or embodied experience, and they're not heard, particularly around pain, whether it's Serena Williams or anybody else. And so we may have actually gotten this backwards. It's not that like people's experience is like this luxury good, it's like the way that you make people safe. So like 7-8 years ago, I got a job as a professor at Harvard Medical School, and I had just finished my training as an OBGYN. And honestly, like I trained at a big tertiary medical center, and like my startle reflex was to do a C-section. And the thing about being an obstetrician is when you do a C-section, you're always right. So like when I did a C-section, if the baby came out and it looked kind of blue and lackluster, I was like, it's a sick baby. It's a good thing I did a C-section. And if I did a C-section and the baby came out with like 99 APGAR scores looking great, I was like, that baby looks great. It's a good thing I did a C-section. It's like pretty good to be me. Like you're like never wrong. And like that challenge has sort of really complicated this drift where, a 500% increase in the use of this major surgery occurred within the professional lifespan of a lot of my colleagues. Like they were around when our C-section rate in our country was 5%, and they were around when it was 32%. But because you're always right, like you can just imagine how that drift occurs. One of the things that I did early in my career in trying to understand like what was going on, it turns out like there are a lot of narratives about this that are not true. So people are like, well, compared to like the 70s and 80s, in the 2020s, like moms are older than they used to be. There's more obesity, there's more hypertension, there's more diabetes, there's more in vitro fertilization, which means there's more twins, and all those things make it more likely to get a C-section. And you're like, okay, but it also turns out that like a healthy 18-year-old today is almost twice as likely to get a C-section as when she was born. So you're like, well, it's not only that. It also turns out like there's still more healthy like young people than like less healthy older people having babies. And so like turns out you can't blame pregnant people or women for C-section rates. It's just not true. And one of the things that we came to believe is what C-section rates really reflect is the degree to which people, this is quality of labor management. What that really means is the degree to which people are supported, basically, throughout their pregnancies and also during labor. So one of the things I did is I traveled around the country. I'd only really seen what it looked like to give birth in Boston. So I spent like a year of my life trying to see what it looks like to give birth in America more generally. And it's really different from place to place. Like a critical access hospital in the panhandle of Oklahoma is very different from a tertiary center or a birthing center in Albuquerque, New Mexico. And one of the things that we saw is like hospitals vary a lot. So the C-section rate in our country by hospital varies from 7% to 70%, depending on which hospital you go to. Sometimes you see that amount of variation within the same city. So like if you're in like Miami-Dade County, like depending on where you are within the same zip code, like your C-section rate odds could like double, triple, quadruple, just based on the hospital you go to. What that means is the biggest risk factor for one of the most common surgeries we perform on people isn't their medical risks or their personal preferences. It's like which hospital they go to. It's kind of nuts. And we developed this theory that, again, isn't rocket science, but it's like in life and in healthcare, we face these dichotomous choices all the time between doing the right thing and doing the easy thing. And often they don't line up. So when somebody's in labor, you can either support them for hours and hours and hours, especially in the face of ambiguous information about how long it's taking or how their baby is doing, or you can just do the C-section, and the C-section will always be easier. And one of the things that we found that explained C-section rates was really surprising. It turned out like the amount of pressure in the system to do a C-section can be determined by something as fundamental as like the architecture of the hospital. So like, turns out every hospital in America has a fire escape map on the wall. Every public use facility has a fire escape map. Turns out that fire escape map is a floor plan. And turns out if people take a picture of their fire escape map and send it to you, you can count how many labor and delivery rooms are on the unit. And then if you also know how many babies they deliver per year, we figured out that you can calculate their C-section rate. That's because, well, we found 2 hospitals on the West Coast that had the same number of labor and delivery rooms, but one place delivered twice as many babies per year as the other. And they both thought they were at their capacity limit. So the only way that's possible is if one place is moving people through way faster. And the way you do that is by doing more C-sections. So we tried to like scientifically prove that that was a thing. The way that we did that was that in Philadelphia in the 90s, half the labor and delivery units closed, which meant, and the population size didn't change, which meant the remaining labor and delivery units got a lot busier. And so we looked at, on the y-axis of all of these graphs, it's like an odds ratio. On the x-axis is the number of people who are simultaneously in labor on the same labor floor. And what it shows is like the busier a labor floor is, the higher the odds will do something that'll speed up the process, like a C-section. And the higher the odds that a person will get hurt, experience a hemorrhage or infection or other things that are driving our maternal mortality rate. And to a certain degree, the way that we take care of people in labor, but that can be extendable to the whole process from, you know, preconception care to the extent it exists, prenatal care, and everything that we do postpartum to like an assembly line. So I don't know, like 4 or 5 years ago, we started to think about like, what do you do about that? We thought one thing we have to do is fix this pressure tank thing. Like we've got to figure out how to make the right thing to do also the easier thing to do. And then we also started to think about the fact that if 90% of the failure points are around communication, we need to figure out how to help people see each other, hear each other, talk together, make decisions together. Spent a year like designing this process where we brought together midwives and obstetricians and nurses and doulas and engineers and spent a good amount of money for an academic institution. And in the end, came up with something that had no technology or AI or anything. It was like stupidly simple. It turns out that every inpatient hospital room in America has a dry erase whiteboard in it. And they're usually for nurses to kind of document things for themselves. They're highly variable in content. And they're small and in a corner. So we made a big one. We organized it and structured it so that it would be simplified and everyone in the room, including the mom herself, could not only see it, but understand it. And it really only has 4 components. Like there's a place where you write down the name of every member of the team, starting with the mom herself and what their role is. There's a place where you write down that person's preferences, a place where you write down the plan, and then a place to write down the next time the team is going to get back together and talk, including the obstetrician, the nurse, the midwife, whoever is there. And that last step is so that moms in America don't feel like a passenger on a plane that's being held on the tarmac without anybody telling them what's going on, which is like most people's experience right now. And it turns out that one step goes a long way towards aligning the whole team. So that was like our idea. And then we wanted to see what it could do. So in like 2018, we decided we were going to run a big federally registered trial of this idea of literally taking the same dry erase whiteboard and making it bigger, but using it as a way of creating, you know, accountability and transparency and structuring the conversations. And we ran this trial on both coasts and in the heartland in Oklahoma and Tulsa among tens of thousands of people that were giving birth and hundreds of clinicians. And what we found was basically the top line messages were among people giving birth, most of them felt they had the role that they wanted in their own care. They understood what was happening to them, and they felt like their preferences made a difference. And that was cool. But what was even cooler is there was what we call a dose response. So the more conversations that occurred that we called huddles in front of this board, the more likely it was that they would believe those things with statistical significance. And then we turned around a survey to the clinicians and asked them, you know, parallel questions. And like the overwhelming majority of them felt like it, you know, they not only didn't hate it, which we thought was a pretty big win because clinicians are kind of ornery when it comes to change, but they felt like it clarified their own C-section decision-making too, which I thought was huge because, like I said, when I do a C-section, I'm always right. And then, you know, what was really kind of amazing is most hospitals not only saw a sustained decrease in their C-section rates, but they saw an improvement in maternal and neonatal outcomes too. There was a decrease in severe maternal morbidity and unexpected newborn complications. And then like a month before the pandemic hit, we were trying to think about how we were going to scale up this idea and do it like in mass with state collaboratives all across the country. And the pandemic scrambled a lot of those plans. And like where we started this conversation was that it really put into stark relief who has been most impacted by this maternal mortality crisis in our country. Black people, Native people, rural people. If you think about the most vulnerable person in America, it's probably the person who's pregnant, who's of color, who's like living in the panhandle of Oklahoma or the Mississippi Delta or places like that. And we had an opportunity then to not actually scale up really fast, but to focus. And what we did instead in the midst of the pandemic is decided to partner with 2 community hospitals that serve North Tulsa. These hospitals at the time had the worst maternal health outcomes in the state of Oklahoma. And Oklahoma has the 4th worst in the country. They were also situated in a community that was literally razed to the ground, as many of you know now, because we just commemorated the 100th anniversary of the 1921 Tulsa race massacre. It's that community. And that community not only was literally razed to the ground, but suffered like so many American communities from redlining and divestment over time. Anyway, we thought if we could use this approach to care there effectively, maybe we could, you know, make other people think that they could do it too, especially with a racial equity lens in mind. The other thing that we thought about was if we were going to do it, we wanted to do it with community members at the lead with us, which was kind of a radical idea too, because even before the pandemic, you can imagine how much mistrust there was in the healthcare system among that community. But there was a community-based organization called the Tulsa Birth Equity Initiative that we were able to partner with in thinking about how we were going to implement the program. And that's ongoing work. We'll have to let you know how that goes. I mean, it may actually massively fail. It sounds really compelling, but it's a different kind of strategy to go to the hardest place and see if you can make it work. But we're all in. We're really, really trying. And we're spending a lot of time on the ground trying to figure out how to make it work. And it's actually been kind of transformative, interestingly, to like bring community members into the clinical setting and try and build trust that way. And we're starting to think about actually how we can get clinicians in street clothes and try to bring them into community settings and have them just listen and model listening, the concerns of community members. The other thing that we've been thinking a lot about is that, effective teams require strong role clarity among the different team members. And nurses are by far the most trustworthy profession in America. It goes like nurses and then like firefighters and then like doctors. There's like a huge drop off from nurses. And this has been true for like a 20-year period in a running Gallup poll. But it also turns out like we don't know a whole lot about how nursing practice influences outcomes from data because nurses on the inpatient side don't bill. So we figured out how to collect a whole bunch of nursing data from when they're logging in and out of computers and figure out basically what the best nurses are doing and define that in terms of basically how likely it is that a patient will have a C-section that a nurse is taking care of. What we found is that there are some nurses that really consistently, the people that take care of have very low C-section rates, and there's some people that are higher. So at Mass General, which is a hospital in Boston, the nurse that you get can influence your odds of getting a C-section 5-fold. And then we found that what the nurses that were doing the best were doing differently is they were like supporting people in labor. They were like at the bedside. They were listening to them. And we actually found out during the pandemic, we surveyed a little over 1,000 nurses, and it turned out that, we thought this was not the most popular project, as you can imagine, but it turned out that most nurses really wanted access to this data, and that transparency goes a long way towards creating trust. Because the thing is, you can't fix what you can't see, and you can't see what you don't measure. It's a little bit like a mixtape of thoughts, but I wanted to make sure that I provided some ideas around not just like this maternal mortality crisis that we're in the middle of, but I wanted to think a little bit about what we can do about it. And part of it, honestly, is redesigning our services and using programs like the one I just mentioned. I've got to say, like, I can't imagine that our healthcare system 5 years from now is going to resemble the one that we have now. This is true in maternal health around the things I described in the inpatient environment. But if you look at just the billions and billions of dollars in the Silicon Valley right now to create technology-enabled platforms that allow people to be seen and heard. Like, it's very unlikely. Like the pandemic really accelerated innovation around models of care on the healthcare side, and also the interest in partnering with community-based organizations where we know that the healthcare system isn't really where health is generated. And I'm expecting there to be like a proliferation of these kinds of new models of care in the next couple of years. It turns out we need more than the means for change, though. We also need like the will for change, which is always the hardest thing. And then we need to codify some of that in public policy. And there's been a lot happening there too. This is a project that I was involved in that we launched a couple of years ago called Expecting More. And it was really just around trying to get empathy for people who give birth. It's interesting to me that like for cancer, if there's like a meeting on Capitol Hill, you can like push a button and there'll be 1,000 people with pink ribbons that'll show up. But for maternal health, it doesn't work that way. Like there's Moms Against Drunk Driving, Moms Against Guns, but there wasn't like a Moms for Moms. And part of that is because I think that moms are sort of generally expected to put their own well-being last, to put their families first. But that's tough. So part of what we've been trying to think about is how to reshape that narrative. A couple years ago, we started a nonprofit called March for Moms, which was trying to be like a Moms for Moms. And the idea was before the pandemic, this was 2019, we gathered people in the mall, put up like a rock concert stage, and we had like families tell their stories, and we invited policymakers to come listen to them. And of course, like last year, in the last 2 years, we had to do it virtually. But what's been kind of amazing to see is that I think that there's been this burgeoning movement in maternal health for a while now that has now just moved from it's essentially like a revolution. What I see happening now, like kind of resembles what was happening with HIV/AIDS in the 80s, where there were a lot of people who were dying, and most of them were from a community that was really stigmatized. And that community organized and totally changed everything. You can't do HIV/AIDS research without a community advisory board now, anywhere in the world. And that kind of community organizing led to a switch from the Reagan administration and the pharmaceutical company giving AIDS patients leftover chemotherapies that didn't work to AZT, which massively improves survival. And the kind of organizing that we're seeing now has led to not just one piece of federal legislation around addressing maternal health to expand access to care, to make sure that we're tracking maternal mortality appropriately, but it's led to this thing, which is the Black Maternal Health Caucus. And they actually have this thing they call the Momnibus, which I think is awesome. It's a whole package of bills that are aiming to improve the current conditions in a variety of ways, from holding hospitals accountable to improving our data systems. And in fact, one of the things that gives me tremendous hope is that we celebrated Black Maternal Health Week a couple months ago. And you may have noticed in the prior picture that the vice president, when she was a senator, was one of the sponsors of that Momnibus package. And actually the White House kind of platformed this issue in April and hosted a whole summit around it, which is a sign of the momentum that we're seeing in our country around really the work that you do, which is trying to take care of people in this period of life. I guess that was a mixtape. I'm not used to having the opportunity to speak to people that do the kind of work that you do. I usually have pretty clinical audiences, but I hope some of that was interesting. And I guess the idea that I'd want to leave you with is that, which of course you know, but in hospitals, we forget that people have needs other than emerging unscathed, right? Like when you're delivering a baby, like mortality is like the floor of what you should expect. It's a low bar. People deserve to be supported and empowered too. So those are some of my thoughts. I don't know, maybe we can hang out and talk a little bit, or
yeah, I think that's great. If folks have questions, we have a lot of people on, so probably easier to type a question in and then, or just even raise your hand if you can, and I'll call on you. Maybe while people are thinking about that. So these are folks who work with a lot of pregnant women who live in marginalized communities. Do you have any ideas for them about how they can be, I don't want to say an advocate because that's probably a little bit of an overreach of their ability, but a support for these women in the area of maternal mortality, ensuring that, I don't know, the moms have a voice? And because I think probably a lot of times moms probably feel like they don't have a whole lot of say. I know that a lot of times it can be overwhelming to be in a doctor's office. You figure this is what I should do. I think about how many, honestly, of my own friends who have had C-sections. And even I was recommended for C-sections just to have a convenient date, which I adamantly refused. But if you don't have that capacity to speak up for yourself or whatever, maybe that would be difficult. Are there ways these folks in working with pregnant women can do that?
Absolutely. Thanks for that question. I mean, I do wish that we were like in person or something so I could turn the question around, because I'd love to hear what you all think. You're the ones who really are spending the time supporting people and probably know far more than I do. And in fact, one of the most humbling things that I think I've come to learn over my career is that like I used to think that I did all the same things that doulas and midwives did, but I also operate. That's not true. Like supporting people who are pregnant, supporting people in labor is a skill set unto itself that is not part of medical training at all. I think that probably the most important thing I can do is just validate how important your work is, and just providing continuity to people and having a presence, because the simple idea that you can be there for somebody if and when they might need you can be very transformative. Pregnancy is at best isolating, whether we're in COVID-19 times or not. In so many ways, it's a time when people are going through such social and biological change and vulnerability. And I think the more that you can just really affirm their dignity and help them elevate their expectations on what they deserve. It is hard. Like, you don't have a lot of agency. When you're pregnant in general, everyone has a take on what you can and can't do. When you're in labor, like you're in labor, one of the concrete things that I think helps clinicians sort of retune is, there's a real complement of expertise between lived experience and technical knowledge. That, childbirth is a team sport for Homo sapiens. It always will be. Like, gorillas deliver their own babies, but their heads are shaped differently. Like, we have dexterity and we have big frontal lobes. Like, we help each other out. We really, there's a pendulum that swung in the early 20th century from really valuing lived experience. Like, the way that you became a midwife was just being someone who gave birth yourself and being around a lot of other births. And then obstetricians sort of took it over because we could wield forceps and now scalpels. And that is important. That saves lives too. But I think we've kind of lost valuing people's, and if you're helping support somebody who feels scared or feels that something isn't right, I think the most important thing that you can do is just empower them to reach out for help, and then remind the clinician on the other end, whose job it is, by the way, to reassure people, because pregnancy is just uncomfortable, and most of our job is to be like, yeah, it's uncomfortable. But if a patient said to me, like, I know this is really normal or common for you, but I'm really scared, this is really unusual for me, like, that would force a pause. And I actually think that forced pause would save lives.
Awesome. That's great information for this group. How about the whiteboard? Are you seeing that show up beyond the hospitals where you tried it out? It looks fascinating.
Yeah, like, so, we did this trial, and now we're scaling up in Michigan and Oklahoma, where we're trying to do it really deliberately. But it's such a simple idea that people have just sort of picked it up organically in the US and other settings elsewhere.
That's great.
Yeah.
Super. Well, I think I don't see any other questions, but I want to just say that I really appreciate you taking time to spend with us. This group has this incredible opportunity to influence such an important part of our population. And I think hearing from you in your perspective is really good for folks to see what's out there and what's happening from a medical perspective, because they're seeing it from another angle as an early Head Start provider. And so this has been super helpful. I really appreciate it. And just for folks' information on the call, our next session in 2 weeks is actually someone who does do doula work in marginalized communities and breastfeeding support in marginalized communities, because of the fact that it is so underrepresented. So it's an interesting thing to see the differences based on the community as to what kind of supports women are getting. So thank you so much. We appreciate it. And hopefully we can touch base with you again as we continue to grow this work and have other opportunities to connect.
Absolutely. I think that the path to trustworthiness requires equity, and that requires bridges between the clinical world and the community world. That's where we started our conversation, and I think how I ended up here. So I'm just so glad that this was of interest to this group.
Yeah.
I would love to continue this conversation, figure out how I can be supportive to your work.
We would love, we're going to take you up on that. So,
Great.
So you will hear from us. You will hear from us. Thank you so much. And thanks to everybody on the call. We'll see you guys in a couple of weeks. And have a great holiday weekend, everybody.
Thank you.
Take care.